Welcome to the Doc to Doc podcast, a podcast about lifestyle medicine, disease prevention, and longevity, with your hosts Dr. Abbas Shafi and Dr. Rob Hoyer. This podcast is for informational purposes only.
Hi, everyone. Welcome to episode 24. We're so glad you're joining us. And tonight we're going to be talking about a very important topic. It's sleep. So we've alluded to this a lot in our previous conversations, but we've never had a full episode on sleep. And this is just a massive topic. Just a few housekeeping items. If you like the videos, please hit the subscribe button. Be sure to hit the upvote us so that others can find us. And we've got a few announcements coming up in the near future, a name change for the podcast, some new logos, a lot of new stuff coming your way. So stay tuned. I'll let Abbas introduce our guest speaker for today. It's Dr. Tim Rummel, and I'll let Abbas do the intro.
It's my pleasure. It's great to have you here, Tim. I know Tim for more than 25 years. He's a studious physician, great colleagues, and superb patient management, as well as good sports. So we have played tennis and pickleball in the past together. Tim finished his graduation at the University of Nebraska. Subsequently, was in Vanderbilt, and presently managing a sleep study at UC Memorial Health in Colorado Springs, as well as practicing improving medicine as well as intensive care. As I mentioned, we know each other for a long time. He has 3 children, 2 boys and girls. Our children seen each other in the past, and we have talked many times about our life here in Colorado Springs. It's an honor to have you here. Tim, go ahead.
Thank you very much. Yeah, pleasure's mine.
So, as Rob mentioned, on many studies shows longevity is associated with many different aspects of the life. One of the most important one is getting adequate sleep. So what do you think, how much sleep should we get, and what are the quality of sleeps?
Yeah, I think you've had to sort of start off with the fact that sleep duration can be individualized. There are some long sleepers and some short sleepers. So you can't make just an absolute rule for each person. On the other hand, and at the same time, if you actually look at all-cause mortality, sleep duration is tightly correlated. It's one of the strongest predictors of lifespan. And it's as you get shorter and shorter, it just dives. It just takes a nosedive and plummets your absolute life duration. So, if you're looking at the average duration of sleep, it's probably 7.5 hours, plus or minus a half an hour. But then as you get under 6 and you get under 5, you can really see a lot of detriments, not just lifespan. You will see cardiovascular risk go up. You'll see risk of cancer. I mean, Rob might be interested in this, is that actually the World Health Organization in the last year or so announced sleep deprivation and sleep limitation, short sleep, is actually a risk factor for cancer. And it makes sense, because of the immune system. Basically, immune system inhibition that goes on when you're chronically sleep deprived.
Yeah, we live in a nation that is, at least in some studies, more than 37%, they do not get 7 hours sleeps. So then consequently, one of the mortality, morbidity, even in accidents, when you don't get adequate sleep, I think it goes 13% of the accidents due to fatigue and lack of sleep, plus many other health issues.
You can see it in a one-day experiment that the Western world decided to do a few decades ago, with daylight savings time. If you look at the cardiac mortality, the day after the clock springs forward, it's up 24%.
Wow.
And then when you look in the fall, when everybody gets an extra hour of sleep, cardiac mortality goes down by 20 or 21%. We just do this experiment every year, So if you think about chronic sleep deprivation, it's really sort of this high adrenaline state all the time with cortisol, high cortisol, high adrenaline, all of those things that in medicine we call the sympathetic outflow. And that with that, you get all the other things, insulin resistance and high growth hormone and appetite for junk food. So getting enough sleep and getting adequate sleep, which obviously means having adequate sleep opportunity, just has to be way up there when it comes to health. And if you really want to pursue health.
In your practice, commonly, what common patient complaint or common disease that you see that, or interesting cases that you see that make you wonder, as a nation, and as as we're gaining weight, we have sleep apneas, and we see it in GI with reflux and many other things. Rob probably sees it with cancer. What are the common things that they come for sleep study, and what are the interesting that you see?
Yeah, I don't just generally have a primary care practice where you're just giving good advice for general health. And that really is probably what's going to have one of the greatest impacts, in the nation. I do think people are becoming more aware and more conscious of sleep. But in our practice, probably 70%, 60% of what we see is we see patients who have sleep apnea or have a suspicion of sleep apnea. And you're right, that's correlated with obesity epidemic, but also, it's overall, it hits about 5% of men over 50 and, 2 to 3% of women. So you just sort of are sitting around in the airport, you're looking at the fat guy who's snoring in his chair, it's going to be 1 out of 20 people in the waiting area waiting for the plane.
Wow. It's heartbreaking. This is, I think, going to be a huge factor in health economic as well in future for for the hospitals, for primary care, as well as for longevity. What are some of the interesting cases besides sleep apnea that you see that is, maybe people, they don't realize it, but they have, sleep deprivation and affect their other health?
Well, I think there's a lot of kind of fun cases. I don't know if you want to talk about the weird cases, or would you like to talk about what I see more commonly?
Maybe both. Maybe a little bit both.
I think probably the second most common syndrome we see is restless leg syndrome. And people will talk about having insomnia or talk about inability to fall asleep, or they'll feel like their sleep isn't very restful or restorative. And it turns out it's restless leg syndrome, and that's just this phenomenon, a little more common in women for sure, where in the evening they start to sense this urge to move their legs and they just can't hold them still. And that's really the sine qua non, is just urge to move. If you actually just tell somebody, hey, I'm not going to let you move your legs, you have to hold them still, they'll go, no, I got to, I have to, And that, when they're trying to fall asleep, they just keep getting this urge over and over. It tends to start in the evening and spill into the first couple hours of the night and then tail off towards the second half of the night. So it's a common cause of having trouble falling asleep. I had one guy who said he didn't have it. He came to see me by himself and he just said, I'm tired. And I was asking him all the regular questions. When his wife came back with him the next time, she said, what are you talking about? She said, you've not only worn a hole in the sheet, you've worn a hole in the mattress. Wow. And actually, one of my colleagues, his wife had restless leg syndrome caused by iron deficiency. So that gets into both of your areas. And when we repleted her iron and got her on a little medication, he complained to me because she wasn't tired anymore.
Of course.
He said, I used to have the evenings to myself. I could watch SportsCenter. I could read a book. I could do whatever I want. And now my wife has all this energy. So I don't know if that's a success or not.
That's right. And what is good sleep pattern? What the people they have, they come over there today with all the anxiety and stress? What you come and tell them? What's the ideal setting for the sleep if you tell them?
I there's kind of just standard sleep hygiene measures, which anybody can look up. But basically, it's having a cool, dark, quiet room. So falling asleep, your body temperature has to fall. You have to cool down to go down. And then actually in the morning, if you warm up, you have to warm up to wake up. So, people can, if they have a real more fine adjustment for their thermostat, they can have the temperature cooler when you're falling asleep and then have it warm up a little bit that hour before you wake up in the morning. If you actually look at why does coffee wake us up in the morning, it starts to wake you up before you have any caffeine blood levels. And the reason it warms you up is the reason it wakes you up is because it's warming you up. Sorry.
Internal temperature. Interesting.
Yeah, so,
I never thought about it.
Yeah, cool and quiet. And everybody needs kind of a short sleep routine that helps them settle down. So not real involved or complicated. And whether that's a little bit of reading or a little bit of quiet time. But I think one of the biggest issues that I see for folks is they don't actually have time in the evening or set time aside in the evening to deal with their thoughts and their plans and their anxieties. So then when their head hits the pillow, that's the first time in the day they've had a chance to think about so-and-so made me angry, or my kids are driving me crazy, or I'm worried about this meeting tomorrow. And it's really one of the better habits and routines to get into is to set some time aside earlier in the evening, not right as you're hitting the bed, to basically go through, if you want to call it a constructive worry list. And for people, obviously people whose head hit the pillow and they just conk out, we don't care what they do. I don't care what they do, right? But they're usually married to an insomniac. So there's usually one insomniac sitting up fretting, and he or she is looking at their spouse who just sleeps, like a bear.
So beautifully, yes.
So the person who has trouble with their anxieties raising in the evening, those are the folks, who it can help to really have, a calming practice, whether it's constructive worry, breathing, meditation, prayer, all of those things.
Or go for a long walk. We see that a lot also with reflux at nights. I think there's two circadian rhythm, night and day, and people that they stay up, then start eating, munching more, and then we get more reflux, then they cannot go to sleep. It becomes a vicious cycle. At the same time, I was studying that if you oversleep, then also it decreases your longevity, both long naps and long sleep. I thought it was very interesting. What's your thought on that?
It really is kind of an inverse bell-shaped curve that way. So short sleep shortens your life. Long sleep is associated with, it's one of those things, though I don't quite understand the causation as much. Sometimes it makes me wonder if that's more of a correlation. In other words, who are the people who spend too much time in bed and sleep a longer amount of time and need more sleep? I think that list is, starts with depressed folks, people with sleep apnea, and some other things that are actually going to associate with mortality that correlates with diabetes and all those sort of things. So I don't know. When I run into people who are sleeping 10 or 11 hours and sleep through the night and wake up refreshed and aren't just lying there, hanging on for an extra couple hours of sleep, it's hard for me to just tell them to get up earlier.
Mm-hmm. So different amount for different folks. But yeah,
there are long sleepers. I mean, those people, if you wake them up at 9.5 hours, they're miserable. They're just miserable. I mean, they're not going to be up in the middle of the night tweeting nasty things to, on Twitter, but they're also, they actually don't function well if you're just in that group that's a long sleeper. So I would say the studies on excess sleep are harder to do, right? It's easier to sleep deprive people. You say, here's your usual amount, or sleep deprive a rat, or whatever experiment you want to do. It's easier to really track those folks and see causation and see the effect.
What do you think of this today's? Of course, the digital device and phones and social media. How have you seen any change? I'm sure you have seen a change in your practice, or what are your thoughts on that?
Yeah, when my son, who's really doing well in school, grad school, he got up at the crack of noon today. And the main reason he got up at the crack of noon is because there was a new Spider-Man video game. And he was telling me how beautiful and wonderful it is, and how creative it is. I said, but there's that bright light and the excitement and the interaction and all that excess vigilance, and excess arousal that happens with a lot of on-screen activities. So even if there's part of what makes social media attractive and gets them to sell advertisements is the anticipation of the next thing. You're looking at that next thing and the next thing, and it's all very short-term stimulation and swipe, swipe, swipe. That really is counteractive and counterproductive when you're talking about what promotes good sleep. Because what promotes good sleep is a lack of arousal, a lack of attention. You're not anticipating anything. You're actually passive, and you drift off. It isn't something you can make yourself do, but it is something that you can inhibit. It is something that you can block.
Great. So what are interesting or strange cases that you see in sleep studies or in your office that commonly that we don't anticipate? Anything very interesting, or what's your
Probably
thoughts?
my most interesting cases, some of my most interesting patients are people with narcolepsy, and that's like 1 out of 2,500 people. So it's not real common, but if there's only a few sleep doctors in the Colorado Springs area and our population, catchment is 1 million, you can kind of see how many narcoleptic patients I might follow. It's dozens, right? And they often not only have the severe sleepiness, but they have this interesting thing called cataplexy. And cataplexy is when you have a strong emotion and you suddenly lose muscle tone. So I've had folks who, one was a semi-pro football player, and when he was the quarterback, and when he would fade back to throw a pass. If it was an easy, short little pass, no problem. If it was a really long pass and he got excited and thought they were going to score a touchdown, he would go limp and he couldn't make the throw.
Wow.
Wow.
I had another lady who played a woman, but she played in a hockey league. And the other team knew that if they got her mad, she would go limp. And her teammates would actually have to shove her off the ice with her just trying to hold on and glide on her skates. And then she could go to the bench, recover her emotions, calm down, get her muscle tone back. So those are kind of pretty interesting cases.
It's amazing.
Tim, is that thought that's the sleep paralysis that's setting in for those individuals who have the cataplexy? Because I believe we're paralyzed when we sleep. So I guess the idea is we don't start flailing and acting out our dreams.
Yes. So that's exactly it. So you can almost kind of think of narcolepsy. So narcolepsy basically have three things: excess sleepiness, non-restorative sleep, and cataplexy. I like to think of it that they have two light switches that are floppy. So one light switch is the light switch that keeps you awake during the day and asleep at night. And that one's floppy. The other one is REM sleep, right? So we all go into REM sleep about every 60 to 90 minutes throughout the night. I mean, this is something that is throughout the mammalian whole, species of all the mammals. They all do REM sleep. And it's about every night, about every 60 to 90 minutes. And your REM periods get longer and longer throughout the night, right? So that's just kind of normal sleep architecture. So it's really only during REM sleep that you've got this active inhibition of your muscle tone coming down from your brain and making your body completely slack. So about the only thing you do is you'll see your dog, right? Their eyes are wiggling a little bit and they just go, "Wah, wah." That's about it. They just got a little yip, nothing else. Well, with narcoleptics, they can go instantly into REM sleep. So we take 60 to 90 minutes, right? We fall asleep, we don't go into REM for an hour and a half. They can go from awake to REM. And they have some components of REM sleep in that they lose their muscle tone, but they have some components of wakefulness in that they're still awake. So they're lying there on the ground staring at everybody, and everybody thinks they passed out, and they can't say, because they're paralyzed, they can't say, "I haven't passed out, I'm actually still awake."
That's
so
wild.
It's a great phenomenon.
And does REM sleep decreases as we age, and how can we improve that? I know that's in elderly is associated with longevity as well. So what's your take?
That's one of the things that we actually don't have a great way of forming sleep architecture to what we like. And it's probably one of the biggest frustrations with people that have sleep trackers is that their sleep tracker postulates, or at least advertise, that it can tell you when you're in deep sleep and REM sleep and this sort of thing. And they'll come and complaining, "I'm not getting enough REM sleep." Well, there isn't a way to make yourself get more REM sleep. So that's something that you can probably correlate, but it isn't something I think you can manipulate. If you look at sleep with aging, there's kind of just normal, healthy aging sleep that a fully healthy, vigorous 60, 70, 80-year-old, right, will have. And yes, they do get less slow wave sleep, and they do get less REM sleep. So it's more light sleep throughout the night. They also have more what's called WASO, wake after sleep onset. So they will spend more of the night awake. But that's even in normal, healthy 75 and 80-year-olds. And oftentimes we have to just kind of explain that to people and say, look, you're getting adequate total sleep time. I can't really change your sleep architecture. You're going to spend a little bit more time awake at night, instead of 5 or 10 or 20 minutes. Nobody sleeps better than a fifth grader, right?
Mm.
I mean, if you guys remember carrying your kids from the car when they were in grade school, they were just dead to the world, dead weight. And as soon as you flopped them into bed, they were already asleep. Well, that's the best it's ever going to get. It's downhill from there.
Mm. What about the effect of the alcohol and marijuana these days on the sleep?
Yeah, bad.
Bad.
It's a dose effect, right? It's a dose effect. All right. So there's an LD50, if you want to call it a lethal, instead of a lethal dose, it's a bad dose to your sleep. And so if you have, for most folks, if they have a beer, if they have a glass of wine, there's not really a significant effect. They may actually just drift off to sleep a little better, right? Maybe because they look at their life in a more positive fashion. But if you get into higher doses, what you'll see is people fall asleep quicker, but then it's a REM suppressant, right? So the first REM period is kind of short, and they'll probably sleep through that. That second REM period comes and they pop awake, and then they're just awake. And that's very common with alcohol sleep, is that you're just awake in the middle of the night because you've suppressed REM sleep. And it's just not as restorative, the whole night. So it's a toxin. If it's mixed with a beautiful wine, though, it's an amazing toxin.
Well, the thing I see so many, sorry, bro, I see so many of my patients today, even earlier, they all have these gummies. This is, oh, they swear, this is, don't take my gummies because, for anesthesia, we tell them not to take any marijuana, anything like that. It's just, I don't know if it's placebo effect or they just has become a daily thing that we see in endoscopy that, we currently we don't want to use any marijuana at least for 48 hours because of anesthesia, but it's hard to believe so many people they're taking those, either smoke marijuana or take the gummies for sleep.
Yeah, and they do need to have a little more research in the marijuana area. And there are different strains that they claim, some are more sedating, some are more excitatory. I think one of the biggest hangups with marijuana is that it does help you fall asleep when you first use it, like a lot of medications. And then it actually enhances slow wave sleep, so a little deeper sleep when you first take it. But as people get more tolerant, if they chase higher and higher doses of THC, then they get withdrawal excitation. And they're anxious when they don't have a certain THC level. So then they're chasing that. And now you're in a real conundrum. And that's really what we're seeing a lot of.
Right.
I have to say, though, I've had a few insomniacs over the years. Beautiful, lovely, conservative 70-year-old lady. I tried everything. We tried all the behavioral stuff. We tried all the counseling stuff. We tried all the relaxation techniques. And then she just came back to me and she says, I just light up every night. I only take a few puffs. I sleep like a baby. I'm never going to see you again. And I said, well, I'm not going to argue with it. So there's probably some patients who, find a small dose that helps and,
and possibly decrease their anxiety or maybe,
that's what I mean.
as you said, that's the stress that they take to bed. Maybe
if their main source of their insomnia was a certain inability to set their anxieties aside, right? So anxiety, you could talk hours on your podcast about anxiety, but anxiety has something to do with this perceived future loss, right? You think you're going to be losing something tomorrow or a month from now, and you're trying to solve that in bed of all places, right? The one place you're not going to take care of stuff that's going to happen a month from now is in bed tonight. And yet that's where people start their rumination. And that's probably more of a soul work, and personality work that people need to do. But that, I'm sure people could write whole books on that.
Tim, I've got to ask you on the topic of substances, caffeine. I'm sure
Yes.
You get a zillion questions about that. How much? How close to bedtime can we use it?
Great question. I think probably the thing that people don't appreciate the most is that the half-life of caffeine is 6 hours, right? So if you take a double espresso in the afternoon, and then that's 3 p.m., at 6 p.m., you still got one espresso. I'm sorry, at 9 p.m., you still got one espresso in your body. And then it's not until 3 a.m. that you're down to a quarter. So most of the caffeine issues have to do with the time of day. If you limit it to the morning, it's really unlikely to be bothering you by bedtime. But there are definitely some signs that people don't completely appreciate how long it lasts, and then they're wondering why they're staying awake at night. There are some interesting studies. There's a recent study on something called the Nappuccino.
The Napa Chino. Okay,
Yeah,
we'll have to look.
yeah.
So people could benefit from a nap in the afternoon, right? I mean, I don't know about our society doesn't really have the nice emphasis and on napping at the siesta time, but there's a lot of wonderful ameliorative benefits of napping, after lunch, right? I was just in another country and the stores aren't even open from noon to 3.
My hometown for 3 to 4 hours.
Yes,
the whole thing can be. Yeah.
Yeah.
Do you think that Nappuccino is because initially when caffeine sort of goes to your brain, relaxes you, then wake you up? Is that because of the initial effect? What's your thought?
The idea is that naps are wonderful and the duration of naps have been studied. So usually it's that 10 to 30 minute nap, which is probably the best duration of the nap, right? Too long and you're going to steal from the sleep bank and you won't fall asleep tonight. Too short, you don't get too much benefit. But part of the issue is there's a little sleep inertia when you first wake up from your nap and you drag. And so the things that have been shown to help you perk back up is if you have a little espresso before the nap. Then the caffeine hits you about the time you wake up. And that's where the Nappuccino comes from.
That's beautiful, beautiful thought.
The other thing that's interesting that's been shown scientifically to really wake you up when you have that kind of draggy, you're dragging after you wake up in the morning, is cold water. And so, we saw it in the old movies when the guy's, trying to wake up, but it actually, it has to be 2 minutes of cold water on your hands and your face. So splash, splash for a whole 2 minutes, which is a long time, right? We're supposed to brush our teeth for 2 minutes. My wife gets there all the time. I never do. And, but that's another thing that'll help you up when you're dragging right after you woke up.
Beautiful. Well, this was an amazing discussion, and I personally learned a lot. So we can go on and on for a long time. Rob, do you have anything else to say?
No, I think that was great. Thank you so much for everything. That was really wonderful. Tim, do you have any social media pages or places where folks can find you if anyone has any questions, or we can certainly forward you questions if we get any from the listeners.
Yeah, I think forwarding my questions, I am definitely not on social media. I'm an old Nebraska boy who's snail mail and landlines.
And you're not old.
I'm the same as you. I'm minimal social media. That's good for your sleep.
Thank you. Yeah.
Well, thank you so much.
No, you're very welcome. It certainly was a pleasure.
Greatly appreciate it. Hope we can talk in future and continue to speak. I'm sure we can talk for hours. Greatly appreciate your time and your information.
Thank you for listening to the end of the podcast, and please listen to another one. It is one of the best ways to help us out. If you'd like to get in touch or just to find more episodes of Doc to Doc, you can find them both at doctordoc.health.